Now we are going to start with a discussion of angina. So till here we have discussed regarding the coronary artery disease, what can be the causes of it, the risk factor associated with the endothelial injury and atherosclerosis plaque formation. We have also seen the basic preventive measures which can actually alter the process of the development of atherosclerosis and prevent the progression of this disease condition. Now, at the beginning of the session, we have already mentioned that this coronary artery disease, although it is a progressive kind of disorder which may or may not show any subjective symptoms in earlier stage of for an individual, but in later on or with a progressive time it may includes the symptoms of angina very prominently in a person who is already having atherosclerosis plaque formation and the occlusion of the coronary arteries, right? So let us discuss now about particular symptoms, that is chronic stable angina, which is very commonly present within a person who is diagnosed or who is suffering from coronary artery disease. And next we are going to see when this chronic stable angina is turning into or progressed into unstable angina and myocardial infarction, we are going to call it as coronary or acute coronary syndrome. So we are going to read about first about the chronic stable angina. Next, we are going to read about the acute coronary syndrome. Under that, we are going to discuss regarding unstable angina as well as myocardial infarction. So first, let us begin with the chronic stable angina. Now, you have to remember one particular thing. Angina or the chest pain is the clinical manifestations of reversible myocardial ischemia. Now, as the term itself is suggesting, the condition is reversible here. Myocardial ischemia means what? The myocardial cells of the heart muscles layer are depriving of adequate oxygen, or we can say it's deprived with the adequate blood supply, right? There is a reason why there is oxygen insufficiency for the myocardial cells of the heart. There is a reason we are going to see the myocardial ischemia is present. Now, angina or chest pain is the primary symptoms of myocardial ischemia, but you have to remember in this stage, this myocardial ischemia is actually in a reversible condition. So, if the person is managed with the basic treatment or if it is, recognized earliest, so the person can actually be saved from going under any progressed disorder or any life-threatening scenario. Now, this angina or this chest pain basically caused because of the increased demand of the oxygen of the myocardium layer of the heart, or else the decreased supply of oxygen through the coronary arteries also can lead to the ischemic conditions of the myocardium layer of the heart. That is the reason the patient would complain about the chest pain or angina. So I hope you are completely clear now that the angina or the chronic stable angina is basically the symptoms associated with the reversible myocardial ischemia. Now, why this angina or chest pain is occurring? Because basically it is happening one, because of an increased demand of the oxygen. How the increased demand of oxygen can occur? It's maybe because of the cardiac workload is increasing. Due to that, the myocardium demand of the oxygen is increasing. That is the reason actually it can lead to ischemia formation. Or else if the blood supply or the oxygen supply through coronary arteries is somehow disrupted, maybe because of atherosclerosis plaque formation, that also can lead to the deprivation of the oxygen in the myocardium, ultimately can lead to the formation of angina. So I hope you are clear about that angina, the basic cause of it. Now, the primary reason for the insufficient blood flow to the myocardium layer of the heart is nothing but the narrowing of coronary arteries via atherosclerosis. Now, as we have learned, the decreased blood supply also can increase, or most of the time will increase the condition or increase the symptoms like angina. Now, it is almost always associated with the narrowing of the coronary arteries because of the atherosclerosis plaque formation. I'll repeat once again, if the coronary arteries, 75% of the coronary arteries are blocked, these are completely occluded with the presence of atherosclerosis, or it can actually produce the symptoms of angina in a particular individual patient. Now, as coronary artery disease is a progressive condition, as we have already learned, patient may be asymptomatic primarily or in an initial stage. For many years, this asymptomatic state can actually be present for a particular individual. Sooner or later, even the person who is already having the atherosclerosis plaque formation in the arteries can show the symptoms of angina. Now, when the myocardial demand of the oxygen will be exceeding the ability of the coronary arteries to supply the oxygen to the heart muscle layer, that is the time when the ischemia will be occurring in the myocardial layer of the heart. So, in a simple term, when the demand of the myocardium cells are increasing, which is basically exceeding the ability of the coronary arteries to supply the adequate amount of oxygen, then the ischemia will occur in the myocardial layer of the heart, and the patient would be showing the symptoms of angina. Now, in cellular level, what happens? The myocardium become hypoxic within first 10 seconds of the coronary occlusion. So you have to remember that it is a very short duration once the coronary occlusion is occurring completely within 10 seconds or for the first 10 seconds. In the cellular level, we are going to see the myocardial muscle cells will be going in a hypoxic state. Now, myocardial cells will be having deprivations of oxygen as well as the glucose. That is the reason the aerobic metabolism, which is normally going on in the myocardial muscle cells for their energy production, will be disrupted. Why the aerobic metabolism is disrupted in the myocardial cells is because of the lack of oxygen and glucose. Now, anaerobic metabolism occurs, or soon we are going to see the anaerobic metabolism starts occurring in the myocardial cell layer. So basically in this stage, we are going to see the myocardial cells will stop having aerobic metabolism. Anaerobic metabolism will start initiating into the myocardium muscle layers, and that is the reason the end product, or as an end product, we are going to see the production of lactic acid. Definitely, once the lactic acid is produced as an end result of anaerobic metabolism, also we are going to see this lactic acid deposition will take place in the muscle layers of the heart. Now, this lactic acid deposition will be irritates the myocardial nerve fibers. Also, this will be transmitting the pain message to the cardiac nerve as well as to the upper thoracic posterior nerve roots. I'll repeat once again, as the anaerobic metabolism is start initiating into the myocardial cell layer, as an end product of this anaerobic metabolism, there will be production of lactic acid. Now, this lactic acid will be getting deposited in the myocardial cells. Now, as this lactic acid deposition is causing some irritation towards the myocardial nerve fibers, it also transmits the pain message to the cardiac nerve as well as the upper thoracic posterior nerve roots. That is the basic cause of the referred cardiac pain, which will be also occurring or also radiating towards the shoulder, the jaw, the neck portions, even the arms. So I hope you are clear once a person is having angina, they will be often complaining about a radiating pain which may start with the left side of the chest, which may radiate towards the upper arm of the left side. It can also affect the areas of the jaw and neck as well as the shoulder areas. So this lactic acid deposition is basically causing this pain and also transmitting the pain towards the cardiac nerve, even the upper thoracic posterior nerve roots. So we are going to see the referred cardiac pain, which is also affecting the areas of upper arm, shoulder, jaw and neck. In ischemic conditions, the cardiac cells actually will be able to viable till 20 minutes. Now, within this 20 minutes, if the condition is managed or cardiac workload is decreased and the coronary arteries are saved from the occlusion, then we are going to see the aerobic metabolism will be restored in the myocardial cells layer, as well as the contractility of the myocardium layer will be restored and cellular repair will begin. If it is exceeding the time gap of 20 minutes, then we are going to see there will be certain complication will be present associated with this myocardium layer. Now here we are going to discuss regarding the factors which basically is influencing the myocardial oxygen need. First, we are going to read about those conditions which basically increasing the oxygen demands or consumption. So the condition includes the aortic stenosis, cardiomyopathy, dysarrhythmias, even the tachycardia. Whereas the conditions which is basically decreasing the blood supply, which is not able to manage the oxygen demand of the heart muscle layers, include the coronary artery spasm, the presence of coronary artery thrombosis, heart failure, even the valvular disease. The next we are going to see about some non-cardiac conditions which affect or which basically increasing the oxygen demand and consumption of the heart muscle layers. Now it includes a condition of stress and anxiety, hypertension, hyperthermia, hyperthyroidism, physical exertion, even the substance abuse. So I hope you are clear. The conditions which is basically increasing the metabolic need or which is basically increasing the oxygen demand of the cardiac muscle layers includes the anxiety or stress, hyperthermia, hyperthyroidism, tension, hypertension, physical exertion, substance abuse, especially cocaine abuse. Next, we are going to read about certain conditions which is basically, decreasing the oxygen supply. Basically includes the conditions of hypoxia, pneumonia, chronic pulmonary or chronic obstructive pulmonary disease, even the hypovolemia. So these are the conditions which is basically affecting the heart muscle layers and its demand of the oxygen, right? So we have seen certain conditions which is increasing the demand of the oxygen. Now if the demand of the oxygen of the myocardium layer will be increased, definitely the coronary arteries ability to supply the blood will be exceeding, right? That is the reason why the coronary artery, even it is supplying adequate amount of blood depends on its ability, the demand won't be matched. Whereas in case where we are seeing certain conditions is disrupting the blood flow or oxygen supply, we are going to see directly it will be affecting the coronary arteries so that the blood flow to the myocardium layer will be disrupted. And in both of the conditions, we are going to see the demand of the oxygen of the myocardium won't be adequately met. That is the reason we are going to see the patient will be showing the symptoms of angina, because as the oxygen demand of the myocardium has not met, the patient may go for the formation of myocardium ischemia. So I hope you are completely aware about the conditions which is affecting the cellular or myocardium cellular oxygen demand, and which is increasing and decreasing the oxygen supply to the muscle layers of the heart. Now we are going to see about a topic of chronic stable angina. Now, chronic stable angina is nothing but it is a kind of angina which basically occurs intermittently over a long period of time with the same pattern of onset, duration and intensity of the symptoms. So I hope you are clear. The chronic stable angina will be intermittent for over a long period. It will be staying and it will be following a same pattern of onset. The duration will be the same and the intensity of the symptoms always will be similar. Patient with chronic stable angina often will be denied of feeling of the pain. Rather than that, they will be describing it as a pressure over the chest or a kind of ache sensation over the chest. So I hope you are clear. A chronic stable angina, if it is present for an individual person, they are not more likely to complain about a sharp chest pain. Rather than that, they will be describing this pain as a feeling of pressure over the chest or a ache over the chest area. Now, this would be also complained as a unpleasant feeling which can be described by a squeezing heavy pain, which also will be the patient will be complaining about a sensation of choking or a suffocating sensation. So you have to remember the chronic stable angina is not likely to change with the changes of position, even with the breathing pattern. Even this chronic stable angina will neither be sharp or stabbing kind of pain. Even the person with chronic stable angina often will be complaining about the indigestion because they will be having a complete burning sensation even in the epigastric region as well. Sensation may radiate to the neck, jaw area, shoulder, even to the upper arm, basically to the left side. So that is the reason the person will be complaining about a radiating pain, as well as sometimes they will be complaining about the indigestion because there will be a burning sensation over the epigastric region. Now, pain will be always present in between the shoulder blade even. So often we are going to see the patient who is having a progressed stage of coronary artery disease and who is present with the chronic stable angina, they will be complaining about the pain or about the chest pain in this way. So certain patient or in certain scenarios, the patient will be completely denial of the chest pain. Rather than that, they will be complaining about a pressure sensation over the chest or a ache will be present in the chest. Some patient will be describing as an unpleasant feeling which can be described as a squeezing, a heavy choking and suffocating sensation. Now, this chronic stable angina will be very rarely having a sharp and throbbing kind of feature, and this chronic stable angina does not likely to change with the changes of position, even with the breathing. Often the patient will be complaining about the indigestion because there will be a burning sensation even with the epigastric region, as well as the sensation or the pain sensation will be radiating to the jaw, shoulder, even to the upper arm, basically to the left side of the upper arm. Pain always will be present, or most commonly the pain can be present even in between the shoulder blades. Now, pain can last for a few minutes, which will be subsiding with the precipitating factors if it is resolved. So there will be certain precipitating factors which basically will be increasing the pain of chronic stable angina. If the precipitating factors are resolved, you are going to see the person would be complaining about a relief from the chronic stable angina for a few minutes. Now we are going to read here about the precipitating factors, which is basically likely to increase the field of chronic stable angina. It includes the physical exertion. Now, you have to remember one particular thing: as the physical exertion or an intense physical activity is increasing the heart rate, reducing the time for the heart to spend on diastole, and also it is increasing the oxygen demand for the myocardial cells layer of the heart. That is the reason why we are going to see here the myocardial cells will be increasing the demand of their oxygen as well, and there will be increase in the heart rate. So the myocardium workload also will be increasing in case of physical exertion or intense physical activity. That is the reason in a physically active state, a person who is already having coronary artery disease would be complaining about the presence of chronic stable angina. Now, the second important precipitating factor is the temperature extremes. Now, in case of extreme temperature, what happens basically here, the workload of the heart is likely to increase, as well as we are going to see the blood vessels will be constricting in response to certain cold stimulus. Blood vessels will be dilating, and also the blood pools will be there in the skin in response to hot stimulus. So both the extreme temperature basically causing the alteration of the blood flow, as well as it is alternating the blood vessels diameter as well as the cardiac workload. So temperature extremes, or both the extreme temperature, whether it can be a extreme hot or extreme cold temperature, can actually induce the chronic stable angina. Now, strong emotions, or basically the environment of stress and anxiety, also induce the chronic stable angina related symptoms. So basically the strong emotions like anxiety or stress basically will stimulate the sympathetic nervous system, which will be activating the stress response, and ultimately this sympathetic nervous system actually can increase the heart rate in a particular individual patient. So as the individual patient's heart rate here is increasing, definitely the workload of the heart will be increasing for the particular individual. Definitely the oxygen demand will be more in such cases or such scenarios. So in case of this stressful scenarios, or where the person is having a strong emotion, the sympathetic nervous system is more likely to increase the heart rate. As here the heart rate of the individual is increasing, definitely the workload of the heart will be increasing and oxygen demand will difficult to meet. That is the reason the person would be complaining about the presence of the symptoms associated with chronic stable angina. Now, consumption of heavy meal can increase the workload of the heart, because during the digestive process the blood is derived from the GI system, right? So reducing the blood flow in the coronary arteries. So basically what happens here, if a person is taking a heavy meal, it is more likely to draw the blood towards the GI system for the digestion process to continue. So that is the time when there will be a less amount of blood supply to the coronary circulation. It may occur if a person is having a very heavy milk consumption. So in this time, definitely, as there will be a decreased blood supply to the coronary circulation, it also may leads to the symptom progression of related to chronic stable angina. The next is the tobacco use or environmental tobacco smoke, or what we call it as indirect smoking, right? Now, or also we call it as a passive smoking. Now, as the nicotine of the with the smoke can actually stimulate the catecholamine release, which is basically causing the vasoconstriction and increase the heart rate for a particular individual, that ultimately can increase the workload of the heart, which is basically associated with the increased demand of the oxygen, and ultimately will be progressing the symptoms related to chronic stable angina. Stimulants like usage of cocaine or certain illicit drug use, which is also will be increasing the heart rate, and that is the reason why there will be symptoms aggregation associated with chronic stable angina. So these are the factors which is basically influencing or directly or indirectly increasing the heart rate for an individual person. Now you have to understand one thing: these factors, if it is present for a particular individual, and if the person is already having coronary artery disease, they definitely would be progressed, or they definitely would be showing the symptoms of chronic stable angina. So I hope you have got the idea that these are the factors which is basically influencing or basically increasing the heart rate and increasing the demand of the oxygen need for the myocardium muscle cells, as well as the decreasing the blood supply towards the myocardium layer of the heart. And that is the reason in these factors we are going to see our individual will be showing the symptoms of chronic stable angina. Now basically we are going to see the chronic stable angina is not likely to present during the time of rest. So if a person is in complete rest with a complete unstressful environment, we are not going to see the client is complaining about this chronic stable angina. So definitely the cardiac workload will be maintained here, so the person won't be showing the symptoms often with chronic stable angina while he or she is on rest. Now a 12-lead ECG will be showing a ST segment depression or a T wave inversion. Now this too will be basically suggesting or indicating myocardial ischemia. Now basically the chronic stable angina will be treated with the medicine in outpatient basis. Chronic stable angina often will be predictable. So medications are timed to provide the peak effects during the time of chronic stable angina attack. So if the angina occurs after the rising of the patient, definitely the patient can take the medication as soon as he or she is awake. Now they can actually wait for 30 minutes to 1 hour before engaging for any physical activity. So basically this would helping the client to avoid to develop the chronic stable angina. So through this, the medication therapy and certain lifestyle modification can help the patient to avoid the development of chronic stable angina. Now, second thing we are going to read about is the silent ischemia. Silent ischemia refers to that kind of ischemia which occurs in the absence of any subjective symptoms. So already we have seen generally the myocardial ischemia, if it is present, definitely the person would be showing angina or a chronic stable angina as a symptoms of it. But in silent ischemia, we are going to see there won't be any kind of subjective symptoms will be present or complained by the patient. But there will be definitely presence of ischemia in the myocardial cell layer. Now, patient with diabetes mellitus will be having a prevalence to have silent ischemia. Why the patient who have diabetes mellitus, they are more prone to get the silent ischemia is because this is due to diabetic neuropathy. As we know, as a complication of diabetes, there can be or a person can suffer from diabetes neuropathy, which is affecting the nerve, which is innervating the cardiovascular system in a patient body or in an individual's body. Now, if the patient is suffering from a chronic diabetes mellitus, as a complication of diabetes mellitus, the nerve can be affected, which is innervating the cardiovascular system. That is the reason we are going to see the person, although they're having a myocardial ischemia, but they won't be having any subjective symptoms or subjective pain associated with the ischemia. Now, when the patient will be monitored for silent ischemia, there can be ECG changes which will be revealing there will be presence of myocardial ischemia. The ECG changes can include the ST segment depression, even the T wave inversion. So that is when the person can be actually diagnosed for a myocardial ischemia. Now, ischemia with or without pain will be having a same prognosis. Now, in case of silent ischemia, if the person is recognized earlier, so definitely the early treatment with the medications can actually help the person to go for a good prognosis. If it is going undiagnosed, the person may develop with some complication sooner or later. Next, we are going to study about a conditions which is known as nocturnal angina or angina decubitus. Now, nocturnal angina occurs at night. Now, you have to remember not necessarily the nocturnal angina will occur when the person is in a recumbent position or during sleep. Basically, this kind of angina will be having a very exclusive feature because it will be occurring during the time of night. Not necessarily the person will be when he is or she is on a recumbent position or during sleep, they will be getting this pain, but only during the night time they will be complaining about this chest pain, and hence this type of angina is called as nocturnal angina. Whereas the angina decubitus is basically the chest pain will be occurring only when the person is in lying down position. Whenever the person will be in standing position or sitting position, they will be completely relieved with this angina decubitus. Next, we are going to read about the Prinzmetal's angina. Basically, this Prinzmetal angina will be occurring at rest. So even if the person is in rest, this Prinzmetal angina will be present for the person. Basically, this Prinzmetal angina occurs for a person. Although it is a very rare form of angina which is basically seen in the patient who basically have a history of migraine or Raynaud's disease. So I hope you got the idea about the Prinzmetal's angina. This is basically occurs because of a response to a spasm of a major coronary artery. Now, it is very rare from a form of angina which is basically seen in a person who have a history of migraine or Raynaud disease. Increased intracellular calcium will increase the spasm of the smooth muscle. That is the basic mechanism of the formation of Prinzmetal angina. Now, the factors which can actually influence the process of Prinzmetal angina development include increased myocardial oxygen demand and pain which may increase during the time of REM stage of sleep, as because the workload or cardiac workload is more likely to increase during this time of or this phase of sleep or REM stage of sleep. That is the reason why we are going to see Prinzmetal angina will be more likely to occur during this stage. Calcium channel blocker and nitrate. These two medications may be used to control this pain. One more type of angina we are going to see is known as microvascular angina. This is because related to the myocardial ischemia associated with the abnormalities which is basically associated with coronary microcirculation. Basically, we are going to see here the atherosclerosis or the occlusion will be occurring in a diffused manner and which will be affecting the coronary microcirculation. Definitely, it will be ultimately causing a myocardial ischemia and will be causing a microvascular angina, which is also known as coronary microvascular disease. So I hope till here you have got a complete idea regarding the varieties of angina which can be present as a progressed stage of coronary artery disease. Now we are going to see regarding the collaborative care which is generally used to treat the conditions of chronic stable angina and associated symptoms. So the treatment basically aims to decrease the oxygen demand or to increase the oxygen supply to the heart muscle layer. So as there is disturbance in oxygen supply and oxygen demand, so basically the collaborative care to manage the angina is focused on to increase the oxygen supply or decrease the oxygen demand of the myocardial layer of the heart. Now, the basic, diagnostic studies definitely will be including the history collection and a physical examination. So, in history collection, you will be asking regarding the present and past health history, whether there is any past history related with family or not, about their lifestyle, which will be basically showing if the person is having a more chances of developing angina associated, like the usage of tobacco or the habit of smoking or alcohol consumption actually increase the chances of the angina development, right? Physical examination or basically will be suggesting the type of pain, the time of the pain or the frequency of it, and whether it is radiating or not. So through history collection and physical examination, a physician or a medical professional can actually conclude whether it is a angina or not. Now to make sure the diagnosis or to conclude the diagnosis, a physician may use the diagnostic procedure like chest x-ray. Chest x-ray will be able to show a cardiomegaly if it is present associated with the myocardial ischemia. Exercise stress test will be showing whether the person is exercise intolerance or whether the myocardial oxygen demand is increasing with the exercise, and whether the body is able to supply the adequate amount of blood to the myocardium layer while the person is in a active state. Echocardiogram will be showing the actual functions of the heart and the chambers of the heart, whether there is any dilatation will be present or any ischemic area is present or not. Nuclear imaging studies is very helpful to find out about the myocardial ischemia. Even in nowadays clinical practice, we are going to see the use of CT scan as well as the positron emission tomography. PET and the electron beam CT scan basically helps to identify the actual localized area of the ischemia. Coronary angiography also is being done to find out whether there is any coronary occlusion is there or not. Laboratory studies for diagnosing the condition includes CBC or complete blood count studies, C-reactive protein, which will be showing or increased state if there is any inflammation is present in the myocardium layer. Homocysteine level, which is very much associated with the formation of myocardial or coronary artery disease. Myoglobin, creatinine kinase, cardiac troponin, even the lipid panel will be helping out to find out whether there is any abnormalities present associated with the myocardium layer of the heart and myocardial activity, as well as this would be definitely showing whether there is an increased chance of the coronary artery disease progression or not. Now, next we are going to see about the management of chronic stable angina, which is basically done with drug therapy. Now, the drugs which are generally used for the managing the client with chronic stable angina include antiplatelet therapy if it is not contraindicated. In case of antiplatelet therapy, physician would be prescribing the aspirin mainly. Nitroglycerin also can be used in the treatment of chronic stable angina, which is basically decreasing the cardiac workload. Angiotensin converting enzyme inhibitors or ACE inhibitors also being used. Beta adrenergic blockers, calcium channel blockers, and lipid lowering drugs. These all are being used to treat the conditions of the coronary artery disease as well as the conditions of chronic stable angina. So that basically the calcium channel blocker, beta adrenergic ACE inhibitors, this all drugs basically helps to reduce the cardiac workload, where the lipid lowering drug will be used to remove the occlusion or remove the chances of lipid deposition in the coronary arteries if there is already presence of fatty streak or chances of coronary artery disease. Now, management of the risk factor associated with coronary artery disease will show a very important or very huge role in the management of chronic stable angina as well. So I hope in the previous session I have already discussed about the conditions which are more likely to increase the progression of the disease of chronic coronary artery disease and management of it. So those lifestyle modification and the management of the risk factors also will be helping to manage the condition of chronic stable angina. As well as a surgical procedure, we may see the usage of coronary revascularization, which basically use the percutaneous coronary intervention as well as the use of coronary artery bypass graft. Now, coronary revascularization through this two procedure, that is percutaneous coronary intervention and coronary artery bypass graft, is very much useful to clear the occlusion of the coronary artery and to maintain the vascularization for the myocardial layer of the heart muscles cells. So this two procedure will be described in later session. So I hope till here you have completely clear about the chronic stable angina and its basic diagnostic studies and management. Next, we are going to see when this chronic stable angina or the coronary artery disease and chronic stable angina will be progressed and form acute coronary syndrome in a patient. What will be the symptoms associated with it, the etiological, the pathophysiological factors and pathophysiological process, as well as the diagnostic studies and the management related to it.